Glucose. It's the spirit molecule that drives our engine and gives every cell energy for us to function. But what happens if it's too high in our bodies? High blood sugar is also known as diabetes. And the reason why we worry so much about diabetes is because it comes with so many different problems down the line. Problems and damage to our eyes, our nerves, our kidneys, our heart. Blood has a similar viscosity to water to allow it to flow easily and supply our organs. Intuitively, you can think about the more glucose there is in your blood, the more syrupy and thick in consistency it will be, and all over less effective. With excess sugar, arteries tend to narrow, developing fatty deposits around the margin and plaque, increasing blood pressure to the end organs and thus damaging them over time. How do we get high blood sugar in the first place? Usually, when we eat food, it gets digested by our digestive tract, becomes these small glucose monomers, gets transported throughout our bloodstream, and gets dumped into the cells, which use it as energy. But right before it enters the cell, it needs to be accepted into the cell. There's a certain lock and key mechanism that occurs here that allows glucose to enter in the cell. The lock, the insulin receptor on the outside of the cell, the key that fits into it is insulin, a hormone that's produced by our pancreas. If at any point the insulin or the lock stops working properly, then glucose isn't going to be able to go into the cell, and your cells are going to be starved, but you're also going to have high blood sugar. Now let's say you have diabetes. How can we control this to make sure we don't get that whole host of problems that we already mentioned? We do use something called hemoglobin A1C to check periodically every 3 months to make sure that your diabetes and blood sugar is remaining in check. Also known as glycated hemoglobin, the amount of blood sugar bound to your hemoglobin, which is inside of your red blood cells, a protein that usually carries oxygen. At baseline, we are supposed to have about 5.7% or less glucose bound to our hemoglobin. 5.7 to 6.4, you're considered pre-diabetic. If it's above 6.4%, then you're considered diabetic. The first step in controlling your diabetes is always going to be lifestyle modification. So this boils down into two things: diet and exercise. If your diet consists of eating 6 to 7 McFlurries a day, you're having a lot of excess sugar in your body, and if you cut back on that, you should ideally have less blood sugar causing you problems. Even if you don't end up losing weight, which by the way is excellent for diabetes, exercise itself, around 30 to 40 minutes of aerobic exercise per day, has shown to reduce this A1C significantly, at least by 1%. You come back 3 months later and your A1C still hasn't budged or has gone in the wrong direction. Now it's time to start medication. First line medications you always want to start with is a miracle drug called Metformin. It acts on the lock part of the lock and key mechanism, the insulin receptor, and sensitizes it. You see, in type 2 diabetes, what ends up happening is that you eat an excess amount of sugar, and the insulin receptor kind of gets used to the insulin and gets desensitized. So it doesn't respond very well. This metformin comes in as a hero and essentially sensitizes it to insulin, allowing the glucose to go into your cell. Metformin blocks gluconeogenesis, new glucose production from your liver. The main side effects someone will experience is upset stomach and diarrhea. Start them at a baby dose of 500 milligrams per day. Make sure they're eating it with food. Titrate up very, very slowly so that they don't have this upset stomach. If all that else fails, then you can always do an extended release, which kind of trickles the metformin over the day rather than having a bolus in the morning and afternoon. So now you come back 3 months later, your A1C hasn't budged even on a 2,000 milligram maximum dose of metformin, or you're not tolerating metformin due to side effects. What do we do now? You do have a whole host of other medications available, but now you start going based off either the side effect profile or based on the person's actual comorbid condition. So the other one you can consider is called a GLP-1 agonist. GLP-1 agonists are basically hormonal analogs of a hormone in our body called incretin. It increases glucose-dependent insulin secretion, so again, increasing the key model of the lock and key model. Also decreases inappropriate glucagon secretion. Glucagon basically stimulates glucose in our body, so less glucose in that aspect. It also does decrease gastric emptying. If you're not gonna absorb glucose in the first place very well, then you're not gonna have high blood sugar. They're specifically great for people who have a risk factor of atherosclerosis or coronary artery disease. Now, the next medication that you want to consider is called an SGLT2 inhibitor. SGLT2 is a receptor found in our kidneys and its purpose is to reabsorb glucose from our body. Now, if we inhibit this reuptake of glucose, we're going to be peeing out all the excess glucose and ridding our blood of excess sugar. If you are peeing out a lot more glucose, it's going to be great for diabetes, but based on osmosis, water following the solid glucose, you're also going to get rid of excess water, excess high blood pressure from your system. And the residual effects of that is it's going to help with chronic kidney disease, which blood pressure damages your kidneys, and it's going to help with heart failure, and high blood pressure also causes damage to that. The side effects are also based on the mechanism of action as well. If you're peeing out glucose, glucose is going to be lingering around a lot more in your urinary tract system, where all those organisms, bacteria, the fungi are going to eat it up and predispose you to a lot more urinary tract infections. You are peeing out a lot more fluid than usual. You are going to be likely to get hypotension or low blood pressure as well. These drugs are also great for weight loss, like GLP-1 agonists. And yet another medication that's great for diabetes is called a sulfonylurea. These sulfonylurea medications are great for kidney disease that's at an end stage. The way these medications work is that it goes to your pancreatic cells and kind of stimulates insulin release, thereby increasing the key model of the lock and key model, allowing glucose into the cell. However, you can already think if you're increasing insulin at a higher rate and allowing glucose to go into the cell at a higher rate, you're gonna probably be predisposed as a side effect to get low blood sugar or hypoglycemia. The other side effect is weight gain because of all this blood sugar going into your cells. Yet another medication is called an alpha glucosidase inhibitor, also known as acarbose. It's kind of unique that it doesn't really act on the lock and key mechanism. It goes right before that when you're digesting and absorbing glucose into your cells. Rather, it slows down the gut and basically delays the absorption of glucose, preventing it from even entering in your bloodstream from the first place. In some special scenarios, your A1C may be really far from goal. It may be, say, greater than 9%. And in this case, whatever medication you're on, you want to either consider starting insulin or adding a GLP-1 agonist if you haven't done so already. Or if you don't like injections like that, who likes poking themselves with needles, you can try triple therapy, which is 3 oral medications. So that can be metformin, sulfonylurea, and in addition to an SGLT2 inhibitor as well. If at any point you start to have symptoms including weight loss, polyuria, peeing out a lot, polydipsia, drinking a lot, this kind of suggests you're having catabolic symptoms, meaning your body's kind of digesting itself because your cells aren't getting enough energy. And at this point, you really do want to consider starting insulin, which is, the last line of therapy in controlling your diabetes. And insulin, you're straight up giving the hormone that is supposed to be the key in the lock and key model here. Problem is, it's an injection, and a lot of people don't like taking injections. And because you're giving the insulin itself, you can get low blood sugar if you get too much. You want to start a very long-acting insulin that covers you for the rest of the day to avoid low blood sugar. You check your blood sugar 3 times per day and at nighttime. If at any time during meals it's elevated, you can give yourself a short-acting insulin and basically titrate the regimen with a doctor as needed. The purpose in going through all these medications was to show you that really there's no cookie-cutter model. Everybody will react differently to some medications, and some medications will work for other people while they may not for you. While diabetes is a difficult condition to control, it shouldn't take over your life. If you just keep working at it, there is likely a medication or a whole host of regimens out there for you that's gonna control your diabetes and let you live the way you want to live life and get back to being yourself.